Now we are going to have Božidar Ferek-Petrić present on ultrasound and evaluation of neuromodulation for dysphagia therapy.
Ladies and gentlemen, Ladies and gentlemen, it's an honor for me, and I'm thankful for invitation of the organizing committee to contribute to this wonderful conference. And I think we're witnessing something unique in the world, how the love of a mother can transform into the scientific project to develop a therapy for a child. Kraljev govor is a small speech and language therapy office run by Željka Vujnović, and I'm an external consultant for the high technology. So which kind of actually neuromodulations we are talking about? It's actually neuromuscular electric stimulation, the therapy that is quite a long time applied in the art. We are not looking at magnetic systems that are really wonderful and new, and there is very little experience in pediatric population. But the latest method, which is the pharyngeal electric stimulation, is really very, very successful, but again, not in pediatric population. So only neuromuscular electric stimulation is present. So little Peter has celebrated his first birthday on the therapy. As you can see, there is superheated. It's a plate that electrostimulates, and the movements of the tongue have been starting very, very soon after that. In deep pharyngeal electric stimulation, we have FDA approval from 2022, but this is really ridiculous that they are putting the lead through the nose that's only applicable in the elderly people. Our little patient, Vít from Maribor, he enjoyed. He is happy to receive this therapy because it was a fine, very nice feeling, but we do it totally in a different way. It's an interferential stimulation by the percutaneous electrodes. The basic principle of it's very, very simplified here, the principle of the neuromodulation. We stimulate the swallowing nerves, the signals are transmitted to the brain. Brain learns again how to swallow. And then swallowing control should be restored. So that is the main principle. But I've been very frustrated when I entered into this arena because I'm coming from the world of cardiac electrotherapy. And there we have guidelines, there we have exact mathematical criteria. Shall we put the implantable defibrillator or cardiac pacemaker to a child? Here, no. You have a lot of problems, and actually the first and major question is, what are the criteria that have been including the patients in the study that are existing? Because the study results are extremely divergent, and you have studies with excellent results, you have the studies with very ambiguous results. So that was the first question. And we tried to find out the method in one non-invasive world, and that's ultrasonics. Directly actually influenced by the article published in 2006, where the Japanese researchers have been using the end-mode color Doppler mode of imaging that doesn't exist anymore. It is old-fashioned, it is abandoned, because we have novel modalities of the ultrasonic scanners operation. But here, they have really measured the velocities of the tongue elevation, and which were normal, but also obviously in elderly population, not pediatrics. ALS, cerebral ataxia, Parkinsonism, polymyopathy, and you see they have noticed that there were severe impediments of the tongue elevation in the case of these pathologies. However, and they used the word ta-ta-ta in order to record all this language. tongue elevations. We are happy in our languages. Tata means daddy. In Japanese, it meant nothing. So we were happy to, we can ask our children to call their daddy in order that we do the measurement. So that is our advantage. And actually, what we do, we scan the tongue in the sagittal plane, where you have the superior longitudinal muscle, transversal vertical muscle, genioglottal muscle, and geniohyoid muscle. This is the tip of the tongue, and this is the root of the tongue. And here
we use in our practice the Samsung
demonstration of our measurement.
PT60 ultrasonic scanner and the LN6 linear probe in infants. After application of the ultrasonic gel, the probe is positioned submentally, directed in the cranial direction. Muscles of the tongue are scanned within the sagittal plane. Parents usually bring the favorite drink of the infant. Everything is feasible, drinking from the glass, by the straw, or from the baby bottle. Adults drink the water from the glass. Pressure of the probe towards the skin must be balanced to maintain the permanent contact with the skin, but preventing discomfort at the same time. Movements of the head will cause the loss of the signal. Normal swallowing has equal time intervals between the swallows. In this example, it is 1.5 seconds. Velocities of the tongue elevations are almost equal, about 8 centimeters per second. One swallow is followed by the long pause and of 3 equal swallows. The tongue hardly moves for a long time. 3 very weak attempts to swallow are visible. After a long pause, the few hypokinetic swallows occur together with the 3 normal swallows.
So, why is that important? It was a wonderful study published by a Japanese group again in Dysphagia in 2019. And what they have really looked again the elevation velocity of the root of the tongue. And you see the healthy and in the case of neurogenic dysphagia, elevation velocity is significantly lower. And not only that, but you can see that actually the first derivative, which is the acceleration of the tongue, is very weak. And that is actually the base of our examination. Here you have a normal swallowing pattern in an infant, and you can clearly see how beautiful you can see 2 elevations of the tongue per 1 swallow, and the peak velocity really goes up to more than 9 centimeters per second. Where do we measure? We measure the velocity here. This is the root of the tongue. This is the tip of the tongue, because it's the sagittal section of the tongue looking from the right side to there. And what is important to say, it's only this small volume. It's so-called ultrasonographers say it's a Doppler-sensitive volume. So you see these 2 small lines. They are designating 1 millimeter wide volume of the muscle, which we observe and record this velocity here on the screen. Well, you have seen Urban today at the beginning of the lectures. Here is his finding. He has fascinating, good results in articulatory kinematics as well as in kinematics of swallowing. At the same time, we have another girl under therapy who has demonstrated really very bad results. So that means that we really need a criteria which is biophysical, like this one, to discriminate, because we have actually only 2 trials with this diagnosis, and they have totally opposite results. So there is something obviously that we still don't know what happens. But anyway, as we have a lot of children who have normal swallowing actually and have never had any problems and only have come due to the articulatory problems, we could easily get one group of 128 kids in order to get some reference. What is the healthy swallowing speed? And you can see, Urban is here, on the right side of the Gaussian distribution. Unbelievable. And you see, these are the velocities, and here are the number of patients that we have. But in swallowing disorders patterns, just look at this last column, please, because this is too much. You have various symptoms. You have totally asymptomatic kid in a swallowing, with the swallowing problems, to moderate. Parents say, oh, he's got a bad appetite. He doesn't like to eat. Well, let's see why. But we have all these 4 patterns. In last 2, we have really demonstrated the problems in swallowing. Have you ever had a situation that you were carrying a heavy weight on the 3rd floor without elevator? So after the 1st floor, you have some difficulties. After the 2nd, more difficulties. After the 3rd, even more. So that's how this root of the tongue feels. Exactly like that. Wonderful. First swallow, then decreasing speed, muscle fatigue, you see? And this is usually 100% asymptomatic swallowing disorder, but it is the swallowing disorder, absolutely. But on the other hand, you have nice rhythmics. And I'm simply professionally obsessed with the rhythmics, because coming from cardiac arrhythmia arena, I look at the rhythmics in the same way. You see, wonderful, wonderful swallows, but hypokinetic. What does it mean? That they have really low, decreased velocity of the tongue elevation. So usually some mild symptoms would develop in that kind of patient. And this is very important. You have totally normokinetic, which means, look, more than 17 centimeters per second, extremely fast, wonderful elevations, but they occur very rarely. What does it say to us? It is not the problem in the oral phase of swallowing. Something is blocking this child to swallow in a normal rhythm. It might be the problem in the swallowing reflex, and that we test with a spoon of Limetta, pure Limetta salts, because that is very sour. And there is an American study that has shown that this is a very nice test for actually swallowing reflex. On the other hand, it might be the problem of cricotheroid muscles and the muscles in due for the 2nd phase of the swallowing. And therefore, you have seen the little boy from Maribor who has been receiving the therapy for the 2nd phase of the swallowing. And now, the worst case, it's the problem in the oral phase. And you can see actually totally arrhythmic and hypokinetic swallowing. So, what is the indication of the therapy? Hypokinesis as well. So here we have, that's just to show you the case of the 15-month-old girl with Joubert-Bolthauser syndrome. This is actually the result of the examination that actually has proven to us that we have to take care about the swallowing of the child with the suprahead electric stimulation. And we did it. After 20 procedures, each lasting 40 minutes, this is her swallowing pattern. It now goes already above 8.8 centimeters per second, and she will come again to further improve this biophysical parameters. So I would say, well, I believe that we are on a real track, that we have found the method which gives us the data upon which we can include the child into the therapy of electric stimulation. So we have 2 days, or no, we have flown yesterday, so 3 days ago, the 781st patient has been examined. So we have quite a huge experience now. And I can say that it's really feasible method to see the articulatory disorders as well as with the swallowing disorders. And what is fascinating, we did the first kinematics of breastfeeding examination in 2018, just 6 months after the University of Brisbane, who were the first in the world to introduce that method. And this is the queen of the methods. It's for a non-verbal child that you know is suckling or breastfeeding. It's for the early intervention, absolutely fascinating examination. This method is really applicable even in the small SLT practice, like this one. We've been 2 years ago at this time in Japan on the Congress of Ultrasound in Speech Therapy, and we have seen producers of fascinating machines for just $20,000 that can be used in such a practice, small, portables. And it's not only for the putting up the indication for the neuromodulation therapy, but also it really can be repeatable, and we can validate the motor recruitment and the follow-up for a long term. That's very, very important. And as a conclusion, well, you can look also at our pages where you can see quite a lot of data, even a lot of patients, because we are, of course, not allowed to publish the patients, but we just copy the parents' Facebook to our side, because parents are so happy about the results of the therapy that they publish a lot of all these movies which you have seen are done and published on the network by parents. So thank you for your attention.
Thank you.